Let me just give you a list of the other stuff so that you'll have that. The Epley maneuver has a couple of questions on it, so make sure that you can work through that and what the Dix Hall pipe is. The functional abilities and goals, that 6-point scale, we're going to talk about that for measuring functional abilities that Jayla had for us.
Who?
When Jayla came and spoke on the functional abilities,
The first one.
yeah.
What?
Oh, I don't think they were.
So we need to, you guys need to come and see me so that I can give you those papers.
Okay.
There's a 6-point scale and we just need to review that, so we'll see what we can do. And then there are going to be 5 postural drainage questions on those 9 positions. So you need to, but I think most y'all have those down pretty well. And then there'll be a number of questions on the balance test. You need to look at what makes them low risk, medium risk, and high risk on all of them. That would be the Berg, the Tonetti, the get up and go, the functional reach. And then I want you to know those balance grades a little bit, so that I need you to know what fair is, especially, and then go from that. If you'll know fair, what fair is and what fair plus is, and then also if there's an assistive device in the gate, what that score is. And then there'll be some questions on the pelvic floor stuff that she had. So we will start with that and go backwards. Oh, and a few questions on the sensory test stuff, but I'll go over some of that a little bit more too.
Do we need to remember the names of them?
Pardon?
Do we need to remember the names of those sensory? Is that what you're talking about, following the thing?
I'll go over that.
Okay.
Just, there's not a lot. I just wanted you to kind of, I'm more interested in that you know a little bit about the diabetic foot eval that we did. So we're going to look at that. So let's go to pelvic floor. So what did y'all learn? What did you learn from her? Because I wasn't here through the whole thing. I sat through it about 4 times, but what did y'all learn?
Look at the rectal exams.
How to do a rectal
That
exam?
they did them, I didn't know they did them.
Oh, you didn't know that?
Yeah, makes sense. But
Well, usually with the female it's vaginal, but with the male it has to be rectal. So,
Right.
yeah. What is she looking for when she does those exams?
She's just trying to palpate the muscle.
So she's palpating muscle, but what's she looking for?
To see if they're like tight or.
Right, yes, she's really looking for the muscle tone of those muscles in there. If they're tighter on one side than another. What is that main external rotator that she brought out to your attention?
I did not understand her, and I was too shy to ask her.
Oh, on your list?
Yeah.
That's the obturator internus.
How do you spell that?
obturatorinternus. So if someone has broken their tailbone and they continue to have pain with that, can we adjust that? Is a PTA, once they're trained, allowed to do internal evals and internal treatment? That surprised me actually a little bit, but I'm glad that that's the truth. What is the treatment? I mean, what is it that if you have someone coming in and they're incontinent, what do you evaluate and what do you tell them? How do you treat them? What do you ask them?
Ask permission to do an internal exam, so you can, I guess, see what's actually going on, or is it going on?
Well, yes, and that's true. You would ask for permission to do that. But that's probably the last thing you do when they came into you. What are some questions you would ask them? If your PT just kind of hands them to you, which may happen a lot of times in your life, by the way. So what kind of questions would you ask someone who's coming to you for incontinence?
How long it's been happening?
How long it's been happening?
Ask them like if it's painful, if they have any pain anywhere.
Is there pain? Are people gonna tell you these issues when they come in? No, I don't. I will tell you that a majority of older women that are probably over the age of 60, if they've had children, will have some issues with it if they haven't addressed it. So it's much more common in women than men, but, so what's something else you might ask?
If they've had an injury.
Right, is there an injury down in that pelvic area? If a woman who's had a pregnancy, did she have a C-section? What, did she have a lot of stitches? Did they have to go on there and do a lot of interstitial work, a lot of fascia work, you know, and actually sew all that pelvic floor back up, because that does happen. So how often did she tell y'all that that someone should go and pee? How often should that be in a normal person?
She said there's not really a range on it.
Right, I would tell you every 2 to 4 hours. I think that's a good range to put down. I think it's important to tell people. So every 2 to 4 hours. It's probably been, she used to say that, so I'm guessing in her practice she finds that, but if someone has to go every 30 minutes, is that too much?
Yes.
Yeah, at least an hour and a half, they should have to do that. Should they be able to sleep all night without having to pee?
Yes.
Yes, they should. So at least 0 to 1 times at night would be considered normal. Get up maybe once. If you get up more than once, then you need to start addressing it. What is some of the behavior things that she talked about that you start telling people to do?
Counting their stream.
Pardon?
Counting their stream.
Right, and how many seconds to really need to pee, how many seconds does your stream need to go before you realize that you actually needed to go?
8 to 12.
Yeah, at least 8 seconds, so let's say 8 seconds. Just put that down and remember that, you need some direction on that, I think. So is that an important thing to tell people? If they're going and just peeing 2 to 3 seconds, then they don't need to go that often. So they've got an issue they need, and it's behavior, most of it's behavior. What makes you need to go to the bathroom? Besides drinking caffeinated drinks that all of you are doing this semester. We don't count that. What's the first thing they tell somebody that has trouble with incontinence? You need to give up caffeine for a while, and let's see if that doesn't help. So you do give up caffeine and anything else that, I can't think of any, mainly caffeine is definitely something that makes you go to the bathroom more. You have to look at people's stress level. Sometimes stress will cause that. So if you have a stream longer than 8 seconds, at least not 8 seconds, then you need to consider it. So what are some things that you do behavior-wise to train them? What would you tell them to do if they needed to go to the bathroom and they really had just gone 30 minutes before that? So what would you tell someone?
Is that to find, like, distract them?
distraction, the first thing you do is you have them say, okay, I want you to sit there a minute and try to think of something else, and just kind of, kind of a distraction. Kind of that's what, they have to do that to themselves though, right? Or they're not thinking, oh, I gotta go to the bathroom. Does that work with you sometimes? Yeah, it does. You get distracted, you thought, it does. What about the quick flick? What did she tell you about that?
4.
How many, did she say 4? Okay. I thought it was more than that, but anyway, I'll put that down. So 4 quick flicks, isn't that what it's called?
Yeah.
Okay. So that's something they can try. And that's just kind of a little Kegel, pulling in. How did she tell you to teach Kegel exercises?
The elevator.
Right. And it's kind of and how many seconds did she tell you to do that and hold it?
4.
4 floors.
Should take 4 seconds to get there where, 4 floors, okay. And how long do you hold it?
I don't know, she said count to 4 and then back down.
And then
So
back
8
down.
seconds.
Okay. So we'll. And how many times do you do it? What do they build up to? What does she build them up to? She does this in her whole practice. She's a strong believer in this. And everything, she used to do it even with all her outpatient stuff she does. She's a great outpatient therapist too, by the way.
She, does progression from sitting to standing to squatting.
Okay, so you start with sitting, and then you do standing. A position she used to teach was to be in supine in a bridge with the ball between your knees and do them. Did she talk about that? Okay. So she's changed her practice a little bit. These are just different ways to do it. So I'd say sitting would be first, and then standing, and then squatting. She builds up to 3 sets of 10. When you first start with someone, how many times can they do it? A lot of times with these ladies. Did she talk about that? Because if you can't pull in and hold it, I say at least 3 seconds, okay? Once you've done your little elevator thing and held it 3 seconds and you can feel that contraction, you should be able to build up to 10. Most of them start out, they can do 2 or 3 if they're incontinent. So she does 3 sets of 10 3 times a week, is what I have always, but she does that with she's a strong believer in doing 3 sets of 10. She learned that, and that's what she does. I personally don't do 3 sets of 10, but I've tried to follow her in this particular thing when I train people in pelvic floor things. So they want to be able to pull up that elevator in a count of 4, and they want to be able to hold it for 10 reps. So that's the beginning. But many of them, again, will start and just be able to do 2 or 3. So did y'all try that with her? Did she have you do it? So how many of y'all could do 10 reps without fatiguing? I would expect most of you to be able to do that. So, and see, did any of y'all tell her that y'all had any bladder problems? You are very young. Does it happen in people your age? Yes, normally if females that have had children, right? If they have problems in those issues.
I think she said she has like a 9-year-old patient once.
Yes. And what'd she tell you about treating children?
Do you not do children?
You never do internal evals on a child under 18. Very wise. I think that you can't always say never, never. You could have a situation where it's going to make a big difference. And so you would bring a mother in, you would, we're dealing with a lot of sexual abuse, we know that. And so in this day and age, and I guess always we've had it, but we're just more aware of it. So you just have to be a little bit more careful, but to be aware that that's going to cause a child a lot of pain and issues like that. Let's see what else do I know about that. How long after any surgery is scar massage useful?
think we ever got.
Yeah, she never did say an actual time.
There is not a time. I know in 10 years, if they're still hurting in that scar, do it. And she literally uses a spoon to do instrument myofascial release. She uses a spoon.
Well, those Graston tools are like thousands of dollars, like the.
Oh, that one, yeah, for sure, those are.
It's just
I've got a
crazy.
really nice one that's about this big. I'll have to bring it and show it to you. But even the ones that Kendall and Bill have are the bigger ones, you know. And so they're easy to do on a thigh, but they would certainly not be so easy to do in certain areas. So, but anyway, scar massage, if that's all we teach you, I mean, with your orthopedic patients, please always check the scars on your patients. If there's some kind of weird pain, it's just interesting. I was gonna tell y'all may have seen the lady that came in with me yesterday. She's a friend of mine, and she fell and had is it called a boxers? Where you break one of your metacarpals. Anyway, she broke the third metacarpal, and so she was in a cast that did not allow her to move her hand, and so all 3 of these fingers were casted so she couldn't move her hand. And I think she wore that 6 weeks, and so she came out of the cast, and the doctor told her she could do whatever she wanted to do. She was pretty well pain-free. She's very limited in some of her range of motion. But she has ridden a huge motorcycle probably for 10 years that I've known her. Our kids grew up together. And she didn't ride just a little motorcycle. I mean, it's a big motorcycle. So she decided that she would go down to Walmart's and back on her motorcycle. She is so sore, she can hardly move. What happens with a hand, and we're gonna learn about this because we're gonna do hand rehab, is it's very easy to cause inflammation in hands. And so I saw her last Thursday, and so I didn't see her until yesterday, which was Tuesday, and I thought, oh, she'll be better. She's not any better at all. So I still think she's inflamed. It's has got me a little concerned. But as a matter of fact, I told her to go get a wrist splint to rest it at night, so that she would have that splint on at night, and then probably during the day when she does a lot of typing, and so it just needs to rest. And so as we get into hand rehab, anyway, I'll have to let y'all come see what she's doing. Interesting. Okay, back to pelvic floor. What is the muscle that wags the tail? Coccygeus.
How do you say that?
Coccygeus, I believe. Is it important to do external stretching for the pelvic floor? Yeah, it is. You need to stretch out those internal and external rotators. How do we do that? What are our 2 major ways to stretch out internal and external rotation? And the piriformis, what's your main piriformis stretch? Knee to opposite shoulder, right? Knee to opposite shoulder is your piriformis stretch. What is your external rotator stretch? Internal rotator, excuse me. See where you cross your ankle over your knee and push down that way and then pull it up? You know that one that...
Is the operator an internal rotator?
It is an external rotator.
Oh, okay. I know this is piriformis and this is obturator. Press down, so that'd be different.
To press down, yeah. Because that would be pressing... Maybe it is. Maybe the internal... I need to look that up whether it's... I believe it probably is an internal rotator as I think about it. Because that's the one that gets tight. Because you stretch it into external rotation. So I'm guessing she just put down hip rotator. She didn't say internal rotator. It is a common problem in people with pelvic floor pain. It's one that gets tight. And she does the same type of myofascial release with that, where she literally just goes in and puts her fingers in and presses for 30 seconds. That is so effective. Have y'all tried that on yourself when you've had a stressed area? And then after you've done that, to do a few isometrics. It's amazing what isometric exercises, how that activates all the muscles in that area and kind of makes everything kind of work. But anyway, okay, let's see if there's anything else I need y'all to know about this. What is physiological quieting? Deep breaths. That's another way of distraction, to change your thought processes. I gotta go to the bathroom, gotta go to the bathroom, gotta go to the bathroom. Should patients empty their bowels at first urge?
Yes.
Yes, yeah. When is peristalsis the strongest?
When you first eat in the morning.
Usually in the morning when you eat. And what is peristalsis? Y'all learned this in midterm, I hope. Yeah, it's the in your intestines, the smooth muscle that moves the stuff down your system. So that's peristalsis. So it's involuntary, but it's stronger in the morning. When people have trouble emptying their bladder, is that always weak muscles? What's the other option? Too tight down there. I think that was such a shock to me that tightness is actually more of a problem than weak muscles. So that's pretty easily fixed. It's such a shock to people. She really only sees people about 4 to 6 visits. And that's amazing when you think about it, that she fixes people that quick. And I know it's kind of a weird area to go into, and Diane never dreamed she would be doing this, I'm just telling you. But she has a major effect on people's lives. Do you realize that? I mean, isn't that what we want to do? Just have a major effect on people's lives? So, anyway. I actually have been trained in the internal because I went to the first class, the pelvic floor class. I don't do that because I don't do it enough to feel comfortable with it. I need to go and work with them and spend some time at Mercy or with a therapist that does it so that I would do it. You know, I need to do it 2 or 3 weeks before I just go and work with the patient. But I do a lot of training on the flick and how to stop and educating that if you're going more than every 2 hours, then we need to look at this. And teach them how to do the elevator. You cannot just tell them how to do it. You must spend that time with them. It's a very boring exercise to work with them, but you need to go over it and over it again because they have to get into the routine of doing it, okay? So it's really an important one for you to spend time with them and actually do it. Don't just say, oh, are you doing your home program? Let's see what else. Is incontinence a normal sign of aging? No. Okay. Any other questions that y'all have on that? Could you go and treat a patient? Yes, you can. You got somebody that's got incontinence, you can treat them with these exercises. You can train them, you can do this patient education. You don't have to go, you cannot do an internal evaluation, but there's a lot of things you can do to work with them. Isn't that what she said in class?
I'm pretty sure it says it on that handout that the scope even includes us doing the internal.
Oh yeah, you can do the internal, but you have to be trained.
Yeah,
You really want
internal
to.
test and measure is not evals, like you said.
Yeah,
No
yeah,
evals.
but to treat.
Right.
But yeah, but once you're trained to do it, you can do it. And I don't mean that any of you need to be trained. I'm just saying you can treat people without doing that. So you guys could go out and treat them right now with the knowledge that you have. Right? If a lady was incontinent and you were doing a home health visit and you started talking to her about it, She's saying, you know, the worst thing in my life is I'm having to go to the bathroom every 30 minutes, so I can't go out and do anything. Could you call the doctor and ask for an order to do a pelvic floor training and strengthening? Yes, you could. And would you know where to start? Yes. Patient education. How often do you have to go pee? What's normal? When you have a stream, you need to count your seconds. How long is it? Y'all know these things. People want to know if they're normal or not. Did you know that? It's really encouraging for people when they know that things are normal. Okay, so that's kind of the question we're going to ask on that. Any questions on pelvic floor? Okay.
What is the elevator? I'm not sure that I remember.
It's where, like you're sitting there and you just kind of think about just pulling everything in.
Okay.
And just kind of pull up like if you need to, and the best time to do it sometimes is when you need to pee a little bit. And so you're just tightening all those muscles up and like it's coming right up to your belly button.
Okay.
And that's going to be your fourth floor.
Okay.
And then you relax it slow, And so, but you know, as you train them, as they bring that up, you'll feel if you can't, I mean, you should do it and see how many you can do. All of a sudden, you'll feel that muscle fatigue and you're not able to hold it. I'm thinking you're supposed to hold it 3 to 5 seconds. Did she not say that?
She counted and it was like 2 seconds between.
Okay, so I would
three.
say, let's say 2 to 3 seconds then,
Yeah.
so that once you pull that up, but do that yourself and see how many you can do before you feel that fatigue in there, okay? We could do it right now, but I'll wait, we might do it at the end. Okay.
Does it help to do those,
I'm doing papers
like
right now.
during pregnancy before you give birth?
I think, it would not hurt, you know?
Does it help in like the birthing process?
I don't think it helps with the birthing process, because that comes from the uterus. So, I doubt it. It wouldn't hurt.
So,
It would strengthen that area if you maybe had more than one child. What happens a lot with that is people tear when the baby's born, and so they tear those muscles out
That's
there.
kind of what I was wondering, if
Yeah.
it helps prevent that, or maybe not. Is there really anything you can do to prevent that?
Have a good person that knows how to deliver babies makes a difference, yes. Yes, sir.
Are the questions about pelvic floor on the test gonna be the stuff that we just, like, went over, like the 8-second P-string, the
Yes.
3x10?
Yes, that kind of stuff.
Okay.
And just know your sheet, because she gave you all those questions.
Yeah,
And then the things we just went over, because I thought she covered that a little more.
we set some different numbers today from what some of the stuff on the paper is, so I was just
Okay, what were the numbers that were different?
I don't remember the 8-second on the stream, I don't know if that was.
Yeah, I thought it was.
I think she
Yeah.
said, 10 to 12.
I said like 18 or
She said 8 to 12.
I think she said 10 to 12. But that's
We're gonna go 8 to 12. I went to class, that's what they told me, 8 seconds, but again, she's changed her practice some because she functions in it all the time. So an 8-second stream means you go to the bathroom.
I think she said anything greater than 8.
Anything greater than 8, okay. So anything greater than 8. Anything else that's questionable? We're doing a 4-second elevator up to the 4th floor. You're gonna hold it for 3 seconds, 2 to 3 seconds. You're gonna build up to how many? 3 sets of 10, how many times a week?
3.
3. How long do these women have to do this to be effective? The rest of their lives is what you will find with them, and so it's hard to tell them that. They do lose it if they don't do their exercises.
Did you say 4-second elevator with 3-second hold?
2 to 3 second hold.
Okay.
And so you start them out with the number they can do, which is 3, and then you start adding, have them add, like you do with all your exercises. But we're gonna build up to 3 sets of 10. And what she does is she does 3 sets of 10 in all 3 positions, I believe. Did she tell you that? So you start in sitting, then you do it in standing, and then you do it in squatting. So that's a lot of exercise, which would probably take at least 15 minutes, right? Then you would do it 3 times a week to maintain. That's what I understand. That's what I learned. Okay, so let's go back to Jayla's stuff. What are the, and you need to write all this down, Aaron and Kari. What are the 3 things in this functional scale that physical therapy grades? What 3 functional things? Like, they do bed mobility, they do transfers, and they do gait, right? So those are the 3 things you're gonna have to grade it whenever you do this system. Who else grades the other stuff?
The OT?
OT and speech.
Can you say those 3 again?
Pardon?
Can you say those 3 again?
They have mobility, transfers, and gait.
Okay.
When did we go over this?
It's when Jayla came and she did a class here. You were here, I think. Jayla came from Encompass.
Oh,
She was talking
the
about,
documentation. God, that seems forever ago.
It has been a while.
And so is 1 the best or the worst?
1 would be the worst.
Okay.
That's total assist. So I've got this sheet for you, and I'll give this to you guys, okay? Let me go get a copy of y'all for right now, just so you'll have it when you're looking at it, while we're talking about it. So you need to go over the 6-point scale and know it. Is there a minimal assistance on the 6-point scale?
We said again.
Is there a minimal assistance on the 6-point scale?
No.
No. So remember, they don't do min assist. Because basically, what min assist was steadying or standby assistance, right? Or contact guard. So they just did away with that. I kind of like that. Supervision or touching assistance is a 4. Remember that 5 is a setup or cleanup assistance. And then moderate assistance is helper does less than half the effort, so 50%. Max assist is helper does more than half. The nice thing about this is it's looking at how much the helper does